Yes. And
Okay,
let me
perfect. And then
go.
if you just give me a minute, I'm gonna just brag on you a little bit, Mariana.
Sure, I'll just start sharing the slides so that we
Yeah,
have them.
just absolutely. Yeah. So it's my pleasure to introduce you to Dr. Mariana Stern, who's an associate director of population sciences at the Norris Comprehensive Cancer Center. And, you know, Dr. Stern's research is basically in cancer epidemiology and covers a broad range of interests. She's really truly an expert in this topic. Everything from etiological to clinical epidemiological studies, like she's, you know, an expert in the field. And her common thread of interest is in cancer health disparities, and she really has a focus on minority populations, mostly Latinos, and also Blacks, and she collaborates with investigators in the Los Angeles Cancer Surveillance Program, conducting studies of cancer patterns among minority populations. So she's also serves as the co-director and co-principal investigator for the Florida, California Cancer Research Education and Engagement Care 2 Health Equity Center, which is NCI-funded partnership. Well, it is an NCI-funded partnership between the Norris Comprehensive Cancer Center, the University of Florida, Florida A&M University, and USC, of course. So she's also a member of the Minorities in Cancer Research Council of the American Association of Cancer Research. She received her undergraduate degree in biology in 1992 from the University of Buenos Aires in Argentina, and a PhD in cancer biology from the University of Texas MD Anderson Cancer Center in 1997, and then also completed her postdoctoral training in epidemiology at the National Institute of Environmental Health Sciences at the NIH back in 2001. So thank you for being here. And we're really excited to hear about your topic today, which is reducing cancer risk, which I think is of great interest to the group here today.
Thank you so much, Budor, for inviting me. And again, apologies to everyone for my mix-up. You know, because this is on a Saturday in my calendar is not so much on my radar, so that's why I got mixed up. But it's a real pleasure for me and an honor to be here talking to you. And what I chose to talk to you today is a topic that is very dear to my heart, which is an overview of what is cancer epidemiology and how can we protect ourselves from developing cancer, or if for those who already have cancer, how to reduce the chances of cancer coming back. So let's just get started, and I will tell you a little bit more about what I'm going to cover in this presentation. And of course, feel free to ask at any point any questions, put them in the chat, or just speak up and I can answer them or wait until the end. So let me see here. So I'm a cancer epidemiologist. I've been working in cancer for, I don't know how many years by now, but many decades. And the reason why many of us work in cancer research is because cancer is the leading cause of death across the world. And by next year, there's going to be close to 90 million people living with cancer around the world, and more than 11 million cancer-related deaths. So, and there's disparities within our country, but also worldwide in terms of cancer patterns. So that's the reason why so many of us dedicate our work to contributing to understanding cancer and hopefully preventing it. So this picture summarizes what are the top cancers that affect our populations here in the US, all populations combined. And on the left, you see the cancers that affect men, and on the right, cancers that affect women. And you can see that for men, the main cancer that occurs among them is prostate, and among women is breast. And the second cancer is the same in both groups, which is lung cancer. And the third cancer is also the same, which is colorectal cancer. So these three cancers, well, four, prostate, breast, lung, and colorectal, are the top cancers that affect people in the US, and they account for the largest proportion of cancer cases. And then you see that there's a lot of other different cancers that they differ a little bit in terms of ranking between men and women. And that account for a smaller proportion of all the cancer cases. And then below, what I'm showing you is the ranking of the deaths that are due to cancer. And what is interesting from this information is that you can see that the top cancers that affect men and women are not necessarily the top cancers that kill men and women. So prostate is the main cancer for men, yet the main cancer that causes death among men is lung cancer, and same in women. And then prostate comes second, and breast. And colorectal cancer is third. Another interesting thing that we learned from this figure is that pancreas cancer, which is not a very common cancer, if you look at the top, you see that pancreas cancer accounts for only 3% of all cancers for both men and women. However, it ranks fourth in terms of cancer mortality, both for men and women. So it's a big cause of mortality, even though not many people get it. So this type of information is very useful to us who work as epidemiologists, because it helps us to understand where should we focus our attention, right? Which are the cancers that account for more of the burden, and which are those rare cancers, and who is experiencing them, so that we can make progress. So as I mentioned, I'm an epidemiologist. So for those of you who are not familiar with that discipline, so I like to think of epidemiologists as cancer detectives, because what we do is we try to understand at the population level why people are getting sick. So, so when you get sick and you don't feel well, you go to a doctor, right? A clinical doctor, and the doctor will examine your symptoms, and based on that will decide, okay, I think this is what you have. And I kind of, based on that, I think this is what caused your disease. So I like to think that as epidemiologists are kind of like that, but for the population. We look at a population and we try to examine the population to figure out what disease does the population have and what can be causing that disease. And the purpose of doing that is so that once we identify what causes that disease, then we can remove that from the population, or protect the population from that if it's something that we can remove, so that the disease can go down. So a big part of our job is trying to identify at the population level what is causing the population to be sick, and also to understand difference in the population and all kinds of other things. So these are the three things that I want to chat with you today. One is, how do we study cancer at the population level? Second is, how do we identify specifically for cancer what causes cancer? And third, to sort of review what have we learned so far, and how can you use that information to protect yourself and your loved ones from developing cancer, or from cancer from coming back. So the way that we study cancer in the population is very straightforward, in the sense that basically what we do is just count. We count people. So, so I'm showing you two examples here that are familiar to me, because as Bodur mentioned, I direct a center that is called the Florida, California Cancer Research, Education, and Engagement Health Equity Center, or CARE2. And Bodur is also part of that center and one of the leaders in the center. So I work very closely with participants and individuals in Florida and here in California. So, so I picked those two examples. So here in California, we have a state mandate that dictates that every time that a patient is diagnosed with cancer, then that information has to be reported to our central registry, which is called the California Cancer Registry. Florida has a similar pattern, and there are many other states around the country that have a very similar setup. Some other states don't, and they only have regional cancer registries that only cover certain areas of the state. But here in California, we cover every single cancer patient. So that means that we know about every single cancer case that occurs in the state. And when I say we, I mean those who are working in the registry. I mean, we as investigators have access to the data without any identifiers. We don't know the names of the people, we just know the information. But those who work in the registry, they get the information from every single patient. And what the people who work at the registry do is they get all this information, they count them, and then based on that, they can make maps like what you're showing here. So on the left, you have the map of Florida, of California, on the right, the map of Florida, and you can see different colors. And that is because they count for each of the counties. They count how many people are getting cancer for every 100,000 people who live in that county. And based on that, they calculate what we call a cancer incidence rate. And the darker the color, in the case of California, means that there's more cases that are happening. So you can see that we have some counties in California where we have, a lot of cases of this is an example of colorectal cancer. And then we have some counties where the incidents are lower. I mean, they're not zero, but they're lower. And same in Florida, you can see that there are some states that have dark brown incidence rates, and then other states that have blue, which counties, which is lower. So we can learn within a state what are the regional variations, and then we can compare across states. So we can see that here in California, overall, there's 37 colorectal cancer cases that happen for every 100,000 people for the period of 2010 and 2014. And then in Florida, for a different period, but similar 2014 to 2018, there's 35 cases that are happening for every 100,000 people. So it looks like here in California, we're getting a little bit more colorectal cancer than in Florida. So doing this counting can help us to identify regional patterns, but also to identify patterns like across larger distances, like across states. And we can do the same thing across different countries as well. So this type of approach is sort of the basic level of epidemiological research, is the kind of the foundation, right? Just counting people and kind of figuring out who's getting disease, where are they getting disease, and asking questions like, why are some people getting more disease than others? Or why are some people not getting as much disease as others? So asking those fundamental questions can give us a lot of important answers. So now let's talk about what causes cancer. So what I'm showing you here is data that highlights the power of one of the most powerful cancer-causing agents that exist in the planet, which is age, right? As we age, the amount of cancer that we get in the population goes up. So what I'm showing you here is on the bottom line is age, and on the left is the amount of cancer that develops per 100,000 people. And you can see that, after populations get around 50 years old, the rate of cancer starts going up pretty rapidly, right? And that's true regardless of what race or ethnicity you have. So I'm showing different colors for the different racial or ethnic groups. So at the top here in the light blue are non-Hispanic white populations. So they accumulate cancer at a much greater amount, followed by non-Hispanic Black populations, and then Hispanic populations, and then lower Asian and Pacific Islander populations. And also, we have some data for American Indian and Alaska Natives, but because the numbers are so small, they're not even showing up here on this figure. So we learn two things from this, right? That with age, the populations get more cancer, right? And it peaks around 80 years old. But the other thing we learn is that not all populations are getting cancer in the same amount, right? So the white population overall gets the most amount of cancer, followed by non-Hispanic Black. Now, if we did this graph for different cancer types, the picture will look a little different. They would all look the same in terms of going up. For the most part, some go up a little earlier, some go up a little later. However, the populations that get affected changes. For many cancers, unfortunately, the African-American population is the one that has the highest burden of disease for a big number of cancers. For other cancers, the Hispanic population has the highest burden. And then for other cancers, the Asian Pacific Islander population. So the rates change depending on the cancer type. And I can give you some examples if you are interested. So I'm going to monitor the chat in case. So maybe, Budur, you can alert me if there's a question in the chat. I want to make sure I see them. So I want to talk about something that I think it's important to understand, which is how do we figure out what causes cancer? And the reason why I want to spend a little bit of time here is because I think talking about things that cause cancer or prevent cancer has become a pretty widespread thing. So when you open the newspaper or when you go on social media, you see a lot of information. You know, eat a lot of this because it prevents cancer, or don't eat this because it causes cancer. There's a lot of information. So I want to give you some tools so that you can learn to distinguish what's really backed by science and important, and you should pay attention on what may not be backed by science or may not be really well established yet. So I want to sort of share with you how do we do this from an epidemiological perspective, so that you can kind of have that inside look. So in epidemiology, we don't get to do a lot of experiments, right? Because we're working with human populations and we can't expose people to things that might be harmful to them, right? That would be unethical. So we observe a lot. So we based our studies a lot, most of the time, by doing observations. So, but as any other scientific discipline, we're guided by hypotheses, right? We postulate things that we think might be true, and then we try to find evidence for that. So our guiding hypothesis, for example, can be that there's a specific exposure that may cause cancer, right? For example, obesity. You know, we may hypothesize that being obese can cause cancer. So one way in which we can try to provide evidence towards this is by comparing groups. So we can get a group of people who are obese and a group of people who aren't, and we can follow them over time and see how much cancer develops in the group with obesity and how much cancer develops in the group without obesity. And then we can compare them and see, are they different, right? And that if we find they're different, that can provide support to our hypothesis. It doesn't prove it, right? Because this is not an experiment, but it provides support. And I can tell you how we can take that a step further. So let's suppose that we want to test a hypothesis that being obese can cause colorectal cancer. So we may recruit 100 people who are obese and 100 who aren't, and we follow them over time. And then maybe we see that among the people with obesity, there's 20 people who develop colorectal cancer after 20 years. And in the group that is not obese, there's only 4 people who develop cancer. So we can calculate different things from these numbers. So we can calculate what we call a risk, which is just, you know, getting the number divided by the total number. And that gives us, you know, a 2%. So basically in the obese group, there was a 2% incidence of colorectal cancer. And in the group without obesity, there was only 0.4%, right? So if we divide 2 by 0.4% so that we can compare the two, we do a ratio, then we get a number of 5, right? So what does this mean? Well, this means that obese individuals are 5 times more likely to develop colorectal cancer than non-obese individuals. And these numbers are made up, right? These are not real numbers. I'm just using them to give you an example. So this is one very commonly used way in which epidemiologists try to put a number to something that we study in the population that we speculate can cause cancer. And it's basically by doing comparisons and a lot of counting. Now, one of the things that us epidemiologists spend a lot of time on is in interpreting these findings. The fact that we find that, right, doesn't mean it's true. There's a lot of possibilities. One is that it could be a chance finding, right? We always have to think about that, and we have ways to scrutinize the data to find evidence of whether it's likely to be a chance finding or not. The second possibility is that it might be a true finding. Maybe obesity is the cause of colorectal cancer, and there is a causal relationship between the two. The other thing we need to think is if we find that a factor increases the risk by 50%, right? Or more percent, like we saw in that example, we have to figure out if that estimate is accurate. Maybe it's not 50%, maybe it's 60%, or maybe it's 20%. The fact that our study finds that number doesn't mean that that number is universal for every person in the population, right? If I did the study 5 times, would I find the same number every time? And the last question that we always ask ourselves is, do the results that we find support our hypothesis, right? For example, the fact that we find that obese individuals are 5 times more likely to develop colorectal cancer. Does that mean that obesity caused colorectal cancer? Or could there be other explanations? Could it be that people who are obese maybe are less physically active? And maybe it's the lack of physical activity that causes cancer. Or could it be that people who are obese are eating a certain type of food, and maybe that food is the cause of colorectal cancer? So we have to consider all these alternative causes, which is something we call confounders in epidemiology, and test them appropriately so that we can understand what is the real relationship here, what is the real cause. Okay. So at the end of the day, epidemiologists contribute a lot of information by doing these comparisons on the population level. And then we have other scientists who do experiments, who work with cell lines. So Dr. Salih is a great example. She works with animal models and cell lines and does all kinds of cool experiments to understand the mechanisms of how cancer develops. So we have a lot of experiments that are done that way. And at the end of the day, all this information gets reported in the scientific world through scientific publications. And these are the vehicle by which we communicate to our peers our findings, right? And a unique characteristic of scientific publications is that they have to be scrutinized by our peers. So when I submit my results from my studies, the journal that I submit will submit my study to at least 3 other people who are going to look at my science and are going to scrutinize it and decide whether it's worthy of publication or not. So this peer review system ensures that what we're sharing with the scientific world follows the scientific method and is sound science, right? So as we do our research, all these publications accumulate. So that's why I like to think that the field of cancer research is held in place by 2 important pillars, right? One is the scientific method, which is what I shared before, the idea that we always start our studies with an idea, we formulate that idea into a hypothesis, then we do observations or experiments, and then we interpret our results. This is the fundamental way in which we do our work. And the other big pillar of cancer research is the peer review system, the fact that what I discover is not just my voice. I cannot just discover something and put it out in the world just like that. I have to go through a system that ensures that what I'm doing is correct. So other colleagues are going to scrutinize my science and give me suggestions of how to make it better, ask critical questions, right? So that means that what gets out finally into a publication in a scientific journal has been scrutinized by at least 3 or 4 people. So any mistakes that I may have made or any wrong assumptions that I may have made in my original experiments can be caught up and corrected by my peers. So I think these 2 columns are fundamental for the cancer research enterprise to work properly. And they're critical for the work that we do in epidemiology, and I'll tell you why. So as I share, we do a lot of observations in epidemiology about what may cause cancer. We publish them. And then what happens is that we have a lot of publications. So if you go into one of our scientific journal databases and you search for papers that have looked at, for example, red meat consumption and colorectal cancer, you may find, and this was only up to year 2020, you may find that there's 700 papers, right, that just talk about that. So a critical question that we have to ask is, do all these papers show the same, right? The same results? And if they don't, why is that? Is it because there are differences in those populations that are reported, or is it because the papers are different, right? There are different ways of doing the studies. What explains that difference? And then the most critical question is, how do we make sense out of that? We have 700 papers saying different things, or, you know, some do one thing, some another. How do we make sense out of that? And this is something that as epidemiologists spend a lot of time thinking about, and is one of our jobs is to figure out, to make sense out of this literature that reports on different populations. So the typical process for doing that is to convene panels of experts that understand those exposures or those topics and to scrutinize all those papers very carefully, because in doing that, we may find that some papers, maybe those studies were not very well done, they have some issues, and that may explain why they're finding what they're finding, and some are really well done, and then we can focus on those and really try to understand what we're learning. So it's kind of like when you have a garden, and you have all your pretty flowers, and then you have your weeds. So you have to go and take out all the weeds, and then you can see clearly all your pretty flowers. It's kind of like the same thing here. There are some studies that are very well done, large populations, very strict science. And then there's some studies that maybe add a lot of noise, but they're small populations, so they were not really well done. So we want to remove those and focus on the good studies and then see what are they telling us. So for anything that has to do with diet and physical activity, there's an organization called the World Cancer Research Fund that periodically does this kind of exercise, convening a large panel of experts, going through all the literature, making sense of it, and then sort of categorizing the evidence based on how strong it is. So for example, here I'm showing you a table of a evaluation they did of some dietary factors like meat, fish, and dairy products. And they found that there was very strong evidence, meaning that there were a lot of papers that were well done, there were large populations that were studied, and they found that there was convincing evidence. So they used different levels of strength of evidence, from convincing to probable to limited, meaning that there's maybe a few studies and maybe they are a little contradictory. So they found there was convincing evidence that eating processed meat and eating red meat can increase the risk of colorectal cancer. And we're going to talk more about that in a few minutes. And then also they found evidence that Cantonese-style salted fish can increase the risk of nasopharynx cancer, which is something that happens mostly in Asian countries. So this is one approach, right, for diet and physical activity. And then we have other organizations that have other approaches, and they focus on other exposures. So the World Health Organization has a very large program where they systematically evaluate different agents that can cause cancer in the population, and also using a similar approach, which is reviewing all the evidence and trying to make sense out of it with a group of experts that really understand it and read every single paper to understand which papers are really contributing informative evidence and what are we learning across all of those. And we have all kinds of tools in epidemiology to do that kind of work. So going back to what I was sharing before, as epidemiologists, we contribute a lot of information about what we observe in the populations, and so do our colleagues who do more basic experimental research. And then at the end of the day, we have a lot of information. And then thanks to these panels of experts that are convened at different organizations, such as the World Health Organization, the World Cancer Research Fund here, for those who live here in California, we have our own program, which is called Proposition 65, and I'm a member of that committee, so I'm very familiar with it, where we evaluate every year several chemicals that are suspected to cause cancer, and we go through all the literature to decide, do we think that this is a harm to our population? And if it is considered to be a harm based on the evidence, then it gets put on what is called the Proposition 65 list. And what that does is that it creates immediately a mandate that any product or any space where that chemical is present and you may be exposed, you need to know. So there's going to be a label on that product that is going to say, this product contains a chemical that has been found to cause cancer in human populations. That way you can make a decision whether you want to purchase that product or not. So California has its own program. I think it's the only state that has that. And because California is such a large state, any company that wants to sell products in California, they have to comply with that list, which means that basically they have to produce products in a way that avoids those harmful chemicals, because otherwise they cannot be sold here in California very easily. So that means that actually what happens in California, it is influencing the product development across the country as well. We also have the environmental toxicology program, which is a government program that also evaluates carcinogens. So we have different organizations that are conducting these type of systematic evaluations and informing one another about different things that may cause. And this is how we find out what are the established causes of cancer. So one key takeaway that I want to leave with you is that, you know, Google is wonderful, right? We learn so much by going to Google, but it can be dangerous because if you want to know, you know, how can I protect myself from cancer, or how, you know, does eating this or doing this can cause cancer or make my cancer to come back, you can find so much information in Google that is overwhelming, and not everything that is out there is going to be is going to come from this very careful process that I share with you here. So what I want to invite you to think about is this idea that when you are evaluating the evidence for whether something causes cancer or not, on the one hand, you have all the amazing information you can get from social media and Google and whatnot. Some of it might be true, but a lot of it isn't. And then you have all this solid scientific evidence that has been carefully curated by experts, right? And that has passed all these important metrics of scientific method. So with that in mind, you know, I invite you to scrutinize what you read and try to question, where is this information coming from? Is it coming from the World Health Organization, from the American Cancer Society? These are all reputable organizations that have used this approach before they put something on their website. So always try to guide the information, or ask questions of the information you're getting, because I can promise you that if you go to Google and find, is it healthy, or is eating red meat bad for you, or is it eating bacon good or bad for you, you're going to find a lot of sites that are going to tell you that bacon is super healthy for you and that you should eat a ton of bacon every day. But what those of us who work in this field and have gone through all this process of evaluating the evidence, multiple organizations have concluded that eating processed meat is known and established by now to cause colorectal cancer. So the scientific evidence says one thing, right? And other sites may say. So always make sure that you base your recommendations from trustworthy sites, which are going to be, and a good way to distinguish them is a trustworthy site is not trying to sell you anything. If you go to a site that is giving you evidence and at the same time telling you, buy our supplements, these are going to be good for you, then I would not trust anything that place says to you. So trust places that are vetted by scientists, like World Health Organization, the World Cancer Research Fund, American Cancer Society, the CDC, etc. So in this final part of the presentation, I want to summarize very quickly, what have we learned to date? What are the key causes of cancer in the population? And this pie here kind of summarizes that, and I'm going to touch upon most of these very quickly. So the main contributor to cancer in the population is tobacco, right? It accounts for 33% of all cancers. And then we have excess weight, which accounts for 20%. And then we have a whole host of other things that we're going to discuss. So tobacco is one of the main cancer-causing agents that we are exposed to through our lifestyle and environment, and it causes a multitude of cancers. I'm just showing some here on this picture, and is known to have more than 70 chemicals in tobacco, combustible tobacco, that are known to cause cancer, and they're very potent, right? And when I mean tobacco, I'm referring mostly cigarettes, but also things like pipe and cigars, and more in the past decades, the emergence of electronic cigarettes, right? So vaping. So the evidence for vaping is more recent because it's a newer vehicle for delivery of tobacco, but there is increasing literature that is showing that being exposed to tobacco vape can also cause in the lungs similar or many alterations that are known to be associated with cancer formation. So we still don't have the strong evidence that as we have for tobacco, because it's a new vehicle and it will take time. So in 20 years from now, we may find this new epidemic of lung cancer because of vaping cigarettes. But the evidence so far is alarming. So, so it's something that we really need to try to reduce in the population. Next, I want to talk about alcohol, which is also an established cancer-causing factor. And until very recently, and it's been associated with at least 6 different types of cancer, right? From colorectal, breast, head and neck, liver, esophagus, and stomach. Until recently, there was a recommendation to stay within what was considered a safe limit, right? So for women, that was 1 alcohol drink per day, and for men, it was 2 drinks per day. But the evidence is increasing at such an alarming rate and is so solid that most recent recommendations that we are giving is to really avoid alcohol as much as possible. And if you're going to do it, just very little occasionally, once in a blue moon, like a treat. But really, there's no safe limit. That's the bottom line. There's no safe limit. Tobacco causes cancer, alcohol causes cancer, and there's really no safe limit. So it's something that we should do if we have to or we want to, but sporadically. So there's the 1 drink per day limit it's no longer recommended. Now I want to talk about things that protect you from cancer. So one key thing that has been established to be a cancer protective factor is dietary fiber, mostly for colorectal cancer, but there's evidence that it can also protect for other cancers because of the influence it has on our microbiome in our intestines and how that can actually have an effect for, our entire body and our brain. So dietary fiber is, what you find when you eat any kind of whole grain or non-starchy vegetable or fruit or legumes like beans and lentils and chickpeas and things like that. And the recommendation is to have at least 5 servings of these products per day, which is about 15 ounces. So basically to try to incorporate them in every meal that you have. And this is just to give you an example of how much, how many grams. So if the goal is 30, 1 plate of veggies with a bit of hummus is about 8 to 10 grams. So if you have 3 of those, then you're set, or a big salad is about 10 grams as well. So, so that's one recommendation, to include them in every meal as much as possible. Now, talking about things that are harmful in our diet, as I mentioned before, there's strong evidence that processed meats are a cause of colorectal cancer, and they potentially could also be a cause for stomach and for breast cancer. And when I talk about processed meats, I mean things like bacon, sausages, hot dogs, salami, ham, all the deli meats, including poultry deli meats. So anything that has been altered to preserve flavor and so that they last longer, right? If you think about it, when you buy salami or ham or sausages, they're pink, right? And they've been there sitting on the shelf for a long time and they stay pink. That is because they've been added some special salts with nitrates that keep them that color. So that preservation method, what it does is it contributes to the formation of cancer-causing agents in your stomach, in your intestines, and that's what we speculate may be contributing to the cancer formation, in addition to other things that we think are happening. So processed meats are an established carcinogen. And then we have red meats that are unprocessed, so fresh meats, right, that you buy, like beef and pork and lamb that you cook. The evidence is a little less strong than for processed meat, but strong enough that there's a recommendation to limit them, not avoid them, because you can eat a little bit of them, but to limit them. So again, the evidence is mostly for avoiding colorectal cancer, pancreas cancer, and prostate cancer. So, so what are the recommendations? The recommendations for red meat, remember, processed meat is to be avoided, like alcohol. Once in a blue moon, you have a little bit of bacon or sausage or whatever, a hot dog, but it should not be part of your daily diet. That's the recommendation. It should not be part of a healthy, regular daily diet. It should be like a treat that you do once in a blue moon. For red meat, it can be part of a healthy diet as long as you keep it to below 18 ounces per week, which is about three portions per week. And portions are small, like a Big Mac or an In-N-Out burger or a deck of cards, right? That's a portion. That's about 3 ounces. So no more than 3 of those per week. And what I like to always recommend is, to move away from the standard old-fashioned American plate that has a big chunk of meat with a, starchy vegetable on the side, and to move to a plate that has a lot of non-starchy vegetables and grains with a little bit of meat, so that you have that taste of meat if you like it, but you are eating a lot of fiber, which is really good for your body. As I mentioned, obesity is a big contributor to cancer risk, and there's many cancers that have been linked to obesity or lack of physical activity. The two are very intertwined. So the recommendation is to be physically active at least 20 minutes per day with a moderately physical activity. And moderate physical activity is anything that gets your heart racing a little faster. Doesn't mean you have to be panting. It can be a brisk walk or gardening, housework, anything that you notice, oh, I'm getting a little tired here. That is a moderate physical activity. It doesn't have to mean you have to jump on a cardio machine and go crazy. Just even dancing, can count. So 20 minutes of that per day is the current recommendation to prevent cancer and to keep a healthy weight. And a healthy weight is being very controversial. There is a suggested range, but people have different body types. So whatever weight is a healthy weight for you, just to keep it there so that you don't go too low or too high. There are several environmental factors that, like air pollution, has been linked to several cancers. There are some pesticides that have been linked to a whole host of different cancers, mostly through, agricultural applications, but also some house pesticides that are used, like glyphosate, to treat weeds. They have been linked to a variety of blood cancers. Of course, being exposed to the sun or sun tanning beds is linked to skin cancer. And then there's various hormonal exposures that have been linked to breast, endometrial, and cervical cancer over the decades, like birth control pills and hormone replacement therapies, etc. There have been linked with different cancers. There's a lot of viruses that can cause cancer. I'll just give you a few examples because I know we are out of time. There's a human papilloma virus that is known to cause cervical cancer. The hepatitis B virus can cause liver cancer. And then there's a bacteria called Helicobacter pylori that can cause stomach cancer. So, but these do not explain here in developed countries like the US. They only explain about 10% of all cancers. In other countries, they explain a larger proportion of cancers. But here in the US, it's less than 10%. And finally, we have genetic mutations, right? Some people are born with mutations that increase the risk of cancer, and ovarian cancer is the cancer that has the greatest proportion of cancers explained by inherited genetic variants, or what we call mutations. But altogether, so there's different proportions of cancers, with ovarian being the highest. But overall, if we look across all cancers, we could say that it's about 5% of cancers altogether that are explained by inherited mutations. Now, among those people that have these inherited mutations, the risk of developing cancer is extremely high. So they have to take preventive measures. And many of you might be familiar with the BRCA1 and BRCA1 mutations, that women who have them then often choose to have preventive mastectomies and to remove their ovaries, because the risk of developing breast and ovarian cancer is very, very high. But altogether, they only explain about 5%. So to wrap up, one key takeaway that I want to share with you is that if we could apply everything that we know so far, all these few things that I mentioned with you about diet, physical activity, alcohol, tobacco, we could prevent 50% of the most common cancers. We could just eliminate 50% of most common cancers if everybody adhere to eating well, staying lean, moving more, not smoking, protecting the skin, getting vaccinated for human papilloma virus, etc. We could prevent 50% of cancer. So even though we don't know everything that causes cancer, what we know is enough to cut the amount of cancer we have in half. And unfortunately, we're not doing enough of that. The other thing we do is we do have ways to detect cancer early. And this is another important tool that we have to help populations stay healthy. We can detect breast, cervical, colorectal, lung, and prostate fairly early if we adhere to these recommended tests at the appropriate age and the appropriate frequency. So if we applied all these things together with the prevention, then we could prevent cancer altogether or detect it early enough when it can be cured. So we have learned that when we apply what we know, for example, thanks to all the knowledge about tobacco, which came from epidemiological research, we have put policies in place that reduce the exposure of populations to tobacco, and people slowly started smoking less and less. And you can see that the incidence of tobacco, showing on the lines on the right, has gone down dramatically over the decades. Now, if we look at lung cancer, there's a new epidemic that is happening, which is the growing incidence of lung cancer among young women who don't smoke, and we don't know what's causing that. So there's always new epidemics that are happening that we have to find out. We also know that since we implemented colorectal cancer screening through fecal tests or through colonoscopies, we see a dramatic reduction in colorectal cancer mortality. A new epidemic, however, is colorectal cancer among very young people. Is growing up, and we don't know why, and those people are not getting screened. So they're being diagnosed with very late stage cancer. And finally, we've seen dramatic reductions in cervical cancer death because of the implementation of Pap screening to detect colorectal cervical cancer very early. So to wrap up, the two takeaways that I have for you is, number one, that the best cure for cancer is to prevent it altogether. And I want to add that for those of you who are cancer survivors, all these same recommendations that we give to prevent cancer, they also apply for preventing recurrence of cancer. So we make the same recommendations for cancer survivors. And the second takeaway is that early detection can help prevent cancer or cure it altogether. Like colorectal, if you do a colonoscopy and they detect a precursor of colorectal cancer, they can remove it, and then cancer will never develop in that person. So it's very important to educate our communities about all these things that we can do to prevent cancer among ourselves and our families, and to empower our communities so that they can get screened so that we can detect cancer early. So I'm gonna stop here, and I will be more than happy to take any questions.
Thank you, Mariana. That was amazing. It was really, really informative.
Okay, I see a question in the chat. Does CDC keep statistics on no cancer diagnosis, or is it just MMWR, morbidity mortality? Thank you for including gardening. Oh, yes, yes. I mean, gardening can be a very, it can get your heart up. When I'm gardening, I definitely get tired, so it counts, right? So if you do that, you get your 20 minutes a day. CDC keeps statistics on you. So cancer diagnoses are typically tracked by the local cancer registry. So there's kind of a division of labor there. So the different cancer registries that are that exist across the United States in different states. And like I said, in some states, we have statewide cancer registries. So the entire state is covered, like here in California. Other states, they have regional registries that only cover some of the larger cities. But all the registries belong to a network of cancer registries, and they pull the data together. So there is an effort from the National Institute of Health to curate all the data so that it can all be collected in the same manner and then put together. And that is called the SEER registry. So that's one big network that covers the entire United States. That then can inform about the state of the nation, right? So that's not done by the CDC. The CDC relies on this information that the National Institute of Health is collecting. And then there's a separate network of additional registries that are part of another network that we can also tap into. And then, of course, the morbidity and mortality weekly reports are pulling in part from the registry efforts, but the CDC tracks many more things other than cancer, right? They track also infectious diseases and other chronic diseases. So they're pulling the data from the different organizations that collect those data. So for example, the SEER registry. Now, the CDC, one of the big jobs, and this came very clear with the COVID pandemic, right? They track infectious diseases. And for that, the way it works is that all the public health organizations or, yeah, offices around the country in the corresponding cities and states, they have a mandate, which is federal mandate, which is that every time there's a list of diseases, infectious diseases that they have to report. So every time that, you know, let's say that I go to the hospital and I get diagnosed with chickenpox, right? That information by law has to be reported to the Los Angeles County Public Health Office. And then the Los Angeles County Public Health Office on a weekly basis reports that information to the CDC. And what that does is that they scrutinize every week the patterns. And if they see a spike, right, it's like, oh, what's going on there, right? What's happening? So they're going to call LA and they're going to say, and that happened a few years ago. I don't know if you remember, there was a measles outbreak at Disneyland, right? So suddenly Los Angeles County is reporting all this high number of measles cases. So CDC will call and say, hey, LA, what's going on there? Should we go? Should we come down and figure it out, or are you okay? So LA Public Health will have to figure out what's causing that epidemic. And if they cannot control it, then CDC will intervene and they will send their special officers. They have special epidemiological officers that get deployed, and they will come and they will intervene to figure out what's happening. So that's the purpose of these weekly reports, which are mostly for infectious diseases. For chronic diseases, for cancer, we have the registries. Unfortunately, we don't have similar registries for other chronic diseases. There are some, but not the same magnitude of cancer. And then CDC will kind of tap on that.
Yeah, that's fantastic.
Okay.
I was gonna, I guess, ask you to, I had a couple of questions myself, but in terms of the early onset colon cancer, has there been any, I mean, obviously we're working on this as a group at USC.
Yes.
It's something that is of interest, but we're kind of studying it sort of after the fact, right? Like, you know, they have cancer. What's the molecular, you know,
Yes.
profile look like, and how could we treat them? But are there any sort of clues as to why the Hispanics, particularly, right, the Hispanic Latino population is sort of getting ravished with early onset colon cancer? I mean, it really is starting to.
Yeah, so we don't have any clues because there hasn't been large enough studies that have looked at that. Some of those are starting to happen now, so we'll have more clues, I suspect, in coming years. But one of the big hypotheses or concerns that we all have is that we also see that there's this really, it's an epidemic, right? We have an epidemic of obesity in our country, particularly among our young population, particularly among our Latino population. Our Latino kids and young adults have much greater percentage of obese individuals than any other racial and ethnic group in the country. And this is growing, so that's why we call it an epidemic. It's truly an epidemic that we're seeing, and which is unfortunately spreading throughout Latin America, because Latin America is adopting a lot of the same lifestyle and dietary habits as the US, and some of the same companies are, you know, having a presence in those countries. So we are starting to see the same phenomena. So that's one concern that as an epidemiologist I have, like, is this obesity epidemic contributing to this increased rise in colorectal cancer that we're seeing in very young people, right? We are seeing people in their 20s and 30s getting diagnosed with colorectal cancer. And the main concern, I mean, colorectal cancer is a curable disease. If it's diagnosed early, it can be treated with surgery, sometimes some preventive chemotherapy, and then that person will be cured forever, right? But what's happening in young people is because they're not recommended for screening. They only notice that there's something is wrong when the cancer is very advanced, because colorectal cancer gives no warning when it's early. The only way we find it is through colonoscopy, right? Or through a blood test,
Right.
A fecal test. So these young people are getting diagnosed when they have symptoms, which means the cancer is advanced, and that compromises their outcomes. So I think diet, obesity, so there's a lot of concern also about the high consumption of sugar and sugar beverages and how that may be contributing to changes in the microbiome and potentially contributing to obesity. So I'm hoping that we can learn more of, there's new studies that have been started, because the other thing is that most of the epidemiological studies we have available to ask these kind of questions, we have a lot of large cohorts around the country that have really helped us identify many of these other factors that I share with you. But those cohorts include people who are older. So we don't have cohorts of young people that we can follow to ask these questions. So that's something that we need to quickly set up, right? To have a cohort of young people that we can follow so that we can ask these questions.
So how many of the young colon cancer cases that are arising, how many of those people are actually obese or overweight? Because presumably
I don't think we have, that's what I mean. I don't think we have like studies that
that
have asked those
information,
questions
yeah.
to have enough data to make those conclusions, right? And that's exactly what we should be doing, to ask questions about their diet, their lifestyle, like do our detective work, right? Like we do always. That's how we
Yeah.
figure out that tobacco causes cancer, by doing detective work in large populations. We don't have those comparable populations. We have to assemble them. And there's a lot of interest in actually starting cohorts of very young people so that we can start asking those questions. Until now, it wasn't really something that anybody was willing to commit effort or money, because cancer has always been a disease of older people, right? Of middle-aged people and older. So the focus has always been there, but now there's an increased effort in like, okay, what's happening with our young populations that are getting these cancers that they're not supposed to be getting, right?
Right. Yeah, absolutely. Yeah, it's a lot of interesting questions and important questions that remain to be answered. Are there other questions for Dr. Stern from everybody? So just, I think right, Mariana, but this group here today these are participants of the Eileen McGeever breast cancer survivorship
Yes.
study. So
Yes. Yeah. And thank you so much for joining. And I hope this was useful to all of you. And yeah, and I'm happy to answer any other questions anybody may have.
Thank you.
It was really excellent presentation and so informative, even for us, scientists. I always, it's always still good to listen and talk to the epidemiologists in the group. Yeah.
Yeah. Yeah, and you have my email, so please feel free to reach out by email if you have any additional, if some more questions pop up later on or whatever, just feel free to reach out. I'm always happy to connect with people and answer questions. And
we can relay too, if anybody also, we can also collate questions. So if you send it to send questions to Audrey,
exactly.
we can collate them and then send them to you, Mariana. That might help streamline. But obviously, like, feel free to reach out to Dr. Stern, no problem. But we can kind of
wanted to see what Ash was up to.
Well, if there aren't any additional questions, thank you all for being here today and for joining in to listen to Dr. Stern. And again, thank you, Dr. Stern, for really a fantastic presentation. It was super
yeah,
wonderful.
you're welcome. And I'm so sorry that I was late. I got messed up thinking it was next Saturday. I think my kids are traveling. I have two boys. Well, they're, for me, they're still babies, but they're 18 and 21. But they're traveling alone for the first time on Monday. They're going abroad. So I'm really nervous and helping them plan. So in my head, I was like, okay, the talk is next week. And, I was looking forward to it. So I'm so sorry I was late, but I'm glad we made it work and that I got to connect with you. And please feel free to reach out anytime.
Yeah, no, absolutely. We're glad that you're okay, because I was like, this is so unlike you that
I know, right?
Genuinely worried that something happened. So I'm so glad.
No. I just got confused. Yes.
All good. And we live to tell. And the recording, so we have a recording, it will go up online for anybody to rewatch the presentation, and also for others who weren't here today to chime in, or if you were late, you can also go back and listen to it. So once again, thank you so much to all of you, and to Audrey and to Dayanara for always checking in with us and being here. Have a wonderful rest of your weekend, and we will see you again in a month's time, roughly thereabouts. Keep your eyes open for the next webinar, which will be, can we just share the date so everybody knows?
Yes, it's going to be August 31st, same time, 10 a.m. Pacific time. And we do have Dr. Kim Miller, who's going to be presenting on young adult survivorship. So she's going to have an exciting talk for us.
Another excellent epidemiologist at USC who will be sharing her thoughts on a very important topic. So please join in, and we'll keep you posted on future webinars. Thanks, everybody.
Bye, everyone.
Bye-bye.
Thank you.